Hi, good afternoon, everyone. I'm hyper aware that I'm the last speaker after 2 days of fantastic talk, so I'll hopefully make it worth your while. Thank you, Harsha, for inviting me. I'm so energized and motivated. He's a powerhouse. Just to put something together at this scale with the type of resources we have, I'm just totally amazed by your energy and passion and commitment. So I'm a rare disease caregiver. I have actually multiple members in the family who all have decided to own their own separate rare disease just to keep life interesting. But my mother was born with a congenital heart defect, and she had a open heart bypass surgery at the age of 21. And she raised us as a single mother, my brother and I. And I think my everlasting memory of this will be just constant breathlessness. And I've seen her go through that for 75 years. Despite having excellent medical management in India, just the constellation of symptoms that she's been suffering with, the breathlessness is sort of is an everlasting memory for me, which was one of the drivers for me entering in the field of healthcare. And then I was very fortunate to spend a lot of time at CHOP, the Children's Hospital of Philadelphia, where I ran a number of their genomics programs for rare diseases. And that's when I really got to know the space of neurodevelopmental disorders and autism, and proceeded to adopt my entrepreneurial Sindhi genes. So for those of you from India, you recognize what that means, but Sindhi is a business community that is from the north of India. And everybody in my family is an entrepreneur other than me. I was looked upon as the black sheep who decided to get into academia, but now I've made them all happy by being part of an entrepreneurial journey as well. So the driver was really understanding the fact that there were so many barriers to just getting access to care. And I'm talking about access to diagnostics. I'm talking about access to intervention, education, next steps, educational, social support, all of that. So most of us know this already. There was an excellent talk by Dr. Gulati right now, is the prevalence of children with autism has increased and really been disturbingly high over the last 40 or 50 years. And today there are 1 in 36 children who have the diagnosis of autism, which has led to this unprecedented demand for all the services that are associated with autism. If you then add all the associated comorbidities that are medical in nature mainly, you are now increasing the number of support services that these children need. If you then add developmental delay to this, then about 10 to 15% of children are really associated with the broader umbrella of neurodevelopmental disorders. And some of the barriers that families face here are 70% of all children with autism actually will be dependent on their caregivers for their entirety of lives, which places an immense stress, financial, economic, emotional burden on those caregivers, which leads to higher divorce rates, parents quitting the workforce, and essentially them planning for what happens to them after they're no longer there. It is estimated by 2060 that the economic cost of caring for children with autism is going to reach $5.6 trillion per year. So this is an urgency. This is a moral imperative that we start addressing this issue. And that was one of the reasons we founded the company. And we are focusing on a number of issues here. But what was really highlighted here was because of the overwhelming amount of information parents face, they're unable to get the diagnosis they need. A typical waiting list to get into CHOP for an autism diagnosis is about 2.5 years. That is after I use all my contacts and people I know there, because I was trying to help a family be seen. The waiting list to get into intervention services, at least in the East Coast, is about 6 months to 9 months. And each of these services are fragmented, which means parents have to go door to door to get speech therapy versus physical therapy versus intervention services. And like I said, there is a strong economic burden on the parents to take care of their children who have autism. So the company was really founded to develop a more integrated approach to do two things: equitable access, and more importantly, early access to diagnosis. We know that children who get an early clinical diagnosis of autism before the age of 3 actually have a higher chance of really being receptive to early intervention strategies and therefore seeing improvements that can help them get mainstreamed. Right now, those are all suffering because of lack of access, period. And so that's the focus of the company. Really, what I wanted to talk about today was a couple of things focused mainly on genetics. The cornerstone of precision medicine is really understanding the genetics behind the patient. We've seen a number of great talks on how genetics can really drive therapeutics forward. And because autism is on a spectrum, we end up seeing cases really that are across the genome, and they are causing a number of different disorders that are linked to the broader diagnosis of dev delay. The roadmap for such patients is therefore not only affording a clinical diagnosis, but really using all technologies that we can get access to, but can get paid for, that can help us molecularly diagnose these children and therefore give them access to early intervention. What's missing sorely is because we have these mom and pop intervention shops in the United States, is there's no central way to really capture the outcomes data in a systematic way to show that the intervention is actually working, which is also a need. And so there's a systematic need to really bring it all together: early diagnosis, molecular diagnosis, early intervention, and then tracking outcomes. And so today the talk was more focused on the molecular diagnostics part. I'm a geneticist, and I trained at CHOP for about 3 years, and then ended up doing a lot of work in the neurodev space there. So I'm going to present some of the work we did, which is related to how we then landed with Opus Genomics. As most of us know, the cornerstone of all patients who present with any kind of dev delay are 3 technologies: exome sequencing, Fragile X, and microarrays. And I've been speaking to some of the attendees here on which one tends to be better. But what we are really anticipating in a very near future state is, because of a lot of advocacy from patient groups and from genetic testing labs in the United States, I don't speak for India, whole genome sequencing will quickly surpass these traditional methods as the first tier test, quickly followed by a rapid whole genome sequencing test, especially for those kids who might be sick. There is a lot of, I would say, excitement around polygenic risk scoring. That's a topic for its own 60-minute talk, so I'm going to skip that. But there is a lot of interest in also assessing risk at a global scale using global chromosomal arrays, but they tend to be less diagnostics and more risk associated. But as part of our work, what we also noticed was new information is coming up a lot. And so I'm going to spend about 2 minutes talking about how we can actually continuously reevaluate genetic data so that we can come up with these new diagnoses on our existing patient cohort. So 2 or 3 slides on that subject coming up in a second. And then we're seeing this increasing need to actually go after these variants of uncertain significance. We all know why they exist. We have millions of them that we're dealing with, but there isn't a systematic way other than segregation analysis to really go after them. And some laboratories are now going after using transcriptomics and others to start really nailing down what these VUSs mean. And so we predict that these 4 testing modalities are quickly going to be the cornerstone of an autism-based diagnostic approach. Our major challenges, and this is actually worldwide, is reimbursement is challenged by 2 things: payers refusing to accept the utility of genetic testing, as well as the monopoly of a single sequencing vendor that most of us are reliant on. And that ends up controlling the cost of the genetic test itself. However, we have a secret weapon, which is informatics. And so while we can't really control the cost of sequencing, in the US, there's a strong labor cost associated with how you analyze the genetic data. So I'm going to talk briefly about what we did to reduce our COGS in that direction. And then, of course, patients, clinicians who are not geneticists do not understand the value of genetic testing or even ordering the test and what they can do with this information. They find it all very overwhelming. And so really providing the right educational resources and support so that this is adopted more universally. Okay, I'm somehow zooming in. There we go. So this is some of the work that I did actually as the head of the genomics lab at the Children's Hospital of Philadelphia. We launched a exome sequencing test, and these are findings that we published on the first 700 cases. Many thousands have been sequenced in that program since then, and I left CHOP about 3 years ago. And so the paper has a lot more detail, but just as we've seen with other exome published studies, 20 to 25% is typically the hit rate for doing an exome sequencing study on really all presentations. And so this is just confirming that detection rate, but then the paper gets into a lot more of the phenotypes that you're more likely to see positive with an exome case versus others. But back when we were doing the study, we quickly realized that because of the US and the regulatory environment we are in, we're being asked to really make sure, because of liability and other issues, to really make sure that a negative test is a negative and a positive is truly a positive, which has caused this astronomical increase in our COGS. So an exome test in India versus the US are widely different. And so we quickly realized that our problem in the US was we couldn't make these genetic tests accessible unless we could reduce the COGS somehow, which were related to analysis and informatics. And so our informatics team within my laboratory really focused on streamlining what that could look like. And really then focusing on like allowing us to develop interpretation platforms that would reduce the COGS. And so the platform itself is called GD Cross. I don't make the fancy names. All the informatics folks make the names for the things we build. And they all resemble like a Transformers movie. But essentially, the goal of the platform is to run through a pipeline, a genome, and then within 1 or 2 minutes, have the diagnostic variant come to the top from the millions of variants. So really have the signal rise up to the top and remove all the noise, but do it correctly with 99% sensitivity and specificity. I won't get into all the details, but we have tested this against some of the publicly available programs like Exomizer and others, and it outperforms many of them using positive cases. 1 minute, okay. And so in the last minute, I want to talk about reanalysis. I haven't really heard people talk about this at the meeting today, but we really need to be aware of the fact that 75% of genetic cases of rare diseases are negative. But these patients are evolving with new clinical information that is not being captured systematically, and the genetic data can be reevaluated. And new information is being published. Every issue of American Journal of Human Genetics has a new autism gene, dev delay gene, intellectual disability gene. But labs are not going back to reanalyze the data for you. And so we've spent most of our time in the last 4 or 5 years really thinking about informatics and how we can automatically reevaluate our cases so that we can increase the detection rate. And we've published a paper that talks about a 17% additional detection rate over the 25% due to a reanalysis algorithm. The paper breaks down what the reasons were for the reanalysis. Not one of them was because we missed a diagnosis in the first place. Almost all of it is because new information came up since we analyzed the patient. The patient had new clinical phenotype, a new gene was published, and that's why we now have a diagnosis. And this work then led to, these are other papers, by the way. So we wrote a paper that reviewed the utility of reanalysis in 2022. So you can look at these papers to see how others have done reanalysis, which is supporting the study we've done. ACMG has published reanalysis guidelines. And then an interdisciplinary group across really major institutions in the US came together. I chaired the working group, and we wrote a framework that helps both clinicians and laboratories really come up with a systematic way to capture the data and then also reanalyze it. So I urge the geneticists in the room to help us like move this message forward. And then real quick for reanalysis, here is a case who was a 9-month-old male at CHOP who was noted to be dysmorphic and completely hypertonic. The doctor who was seeing him actually came to my office and then walked me home because he wanted to talk about the case. So you can recognize what the importance of the case was. We ended up sequencing him. He was negative by another testing company, and this is a reanalysis case. He had multiple family members, cousins, and siblings who had either died of the condition or were at CHOP being seen. All of them were in a coma for 2 years or more. We ended up sequencing the case and identified a new gene, ended up obtaining emergency IND approval for a drug that was actually being used to treat seizures. And this is all published in this publication, but really highlights the the CHOP sort of mission to even find precision medicine therapy for an N of 1. So I just wanted to end with the case. It was a very moving case for me. We spent a lot of time sort of working on identifying this gene, and to see it get to treatment was very fulfilling. Many such cases and stories have been published with our group. And then finally, I'd just like to say, this is what we're going to talk about at the panel, but I'd like to make a strong case for sharing data across the two countries, and also really going beyond genomics to do omics at a higher level so we can understand how diseases work and function. I'll stop there. Thank you.